Okay, I was actually introduced to Dr. Huang by one of the medical officer who worked with her, I think. I can't even remember. I think the medical officer's name is
Dr.
the
Yong.
medical officer is here, Yong. Yong, is it?
Ah,
Yong, yeah. So Yong actually corresponded with me over some other matters. I think it was a job, and then got to know that she was actually she had a master's in forensic pathology, a diploma, diploma in forensic pathology, I think. So she introduced me to you, and then we started talking. And thank you very much for accepting to give a webinar to all of us who are completely ignorant about forensic pathology. We seem to think it's a very glamorous job from CSI that we watched. But maybe you can tell us more, and then later we'll go through your slides first. If any questions, okay, I'm sure there's a lot of questions also, not just about your slides, but also about your profession eventually. So without further ado, we get started.
okay, good evening. I'm Dr. Huang. Can you hear me?
Yes.
Yes, so can I start now?
Yes.
Okay, good evening. I'm Dr. Huang. I'm currently the forensic pathologist working in Sarawak General Hospital, Kuching for around 2 years already. Okay, I am originally from Sarawak also lah. And today I was being invited to present some interesting cases lah. And today I'm going to share two rare cases of pediatric death, which is of a manner is natural death lah. Okay, let us start two cases, and then after that 2 cases will be the theory part lah. Okay, the dry part of the disease lah. Okay. So case 1 is a 3-month-old term girl had episodes of poor feeding, gasping, associated with bluish lips and inconsolable cry for a few days. She became unresponsive and pronounced dead by ETD later. So the Pol-61 was being ordered, and then we proceed for postmortem examination. Externally, there was no suspicious injury, no dysmorphism, no deformity, no jaundice. This is the picture of the baby girl, 3-month-old baby girl. And then you can see there is some dark red discoloration on the chest, over the anterior of the chest. Actually, this is a bruise, which is consistent with CPR, okay? This is by CPR. Okay, this is some just medical intervention during the resuscitation. Okay, the growth parameters show that a bit at the lower border for the body weight BMI, and crown heel length and other parameters was still in the normal range. And the head circumference still acceptable. And then we proceed to the head examination. We open the skull vault. Okay, when we open the skull vault, we can examine the brain already. There was no cerebral edema, as the sulcus was not flattened, and then the gyri was not narrowed. Okay, and then this is the superior view of the brain. This is the basal view of the brain. This is the olfactory bulb. This is the optic chiasm. This is the brain stem. This is the cerebellum. This is the cerebrum. Okay, and this is the lateral view of the brain. This is the normal brain finding. And we cut the brain. This is the cross-section pictures of the brain. The left side of the picture is the left of the brain. We are looking into the brain, the cross-section from the back of the head. Okay. This is the cerebrum cross-section. This is the brainstem cross-section, and this is the right and left side of the cerebellum cross-section. They are normal. There was no cerebral edema, no pus, no meningeal bleed, no intracranial bleed, no hydrocephalus, and no space-occupying lesion. Wait, I remove this panel. So next we proceed to chest and abdomen examination, opening of the skin incision, the wide incision at the neck, and then the incision continue down, avoid the umbilicus and toward the pubic symphysis, and we open the peritoneum and saw that this peritoneum is healthy because the peritoneal wall was shiny, glistening, as well as the intestine. But however, when we look into it, the pocket of the peritoneum, there was ascites, straw color free 20 mil of ascites, and there was bilateral pleural effusion also. This showed the sign of a third space fluid retention. And then we proceed to examination of the chest. Okay, the chest cavity, we remove the sternum and the rib, and then it reveal the thymus. This is the thymus, and this is the pericardial sac with its heart inside there, and this is the border of our right lung. And then there was cardiomegaly. Okay, opening of the pericardial sac. So there was pericardial effusion, straw color fluid of 10 mil. Another sign of third space fluid retention. Then we proceed with examination of the heart in situ. Okay, first we remove the thymus just now, and then we trim the pericardial sac so that we can examine the great vessel of the heart. This is the trachea, okay, and this is the aorta. This is the ascending, the arch, and then the descending aorta. This is the pulmonary artery. And the aorta give out to the branches of right brachiocephalic artery, left common carotid artery, and left subclavian artery. This is the right lung, and this is the left lung, and you can see some pleural effusion just now. That was already has some blood staining. Okay, this is accidental made by us lah. Okay, and this actually there was PDA there. I'll show you the pictures of the PDA of this case. And then for all these, other than that, all these great vessels, there was no coagulation of aorta, and they are in their normal anatomical position. And we go into the examination of the heart. Okay, first we cut into the IVC to the SVC, and then into the right atrium. And then from right atrium, we cut into the right ventricle. This picture shows the internal wall of the right ventricle. Okay, the interventricular septum was intact. There was no ASD, VSD. And then the endocardium did not show any non-completion cardiomyopathy. However, there was some diffuse, some minimal whitish discoloration of the internal wall of the heart. The heart layer, the layer has a 3 layer lah. The internal one is the endocardium. The middle one is the myocardium. And then the most external one is the epicardium. The coronary artery situated. Okay. And for this is what we saw now is endocardium lah. And there was some whitish discoloration. Okay. And then from the right ventricle, we continue our cut into the pulmonary artery. And at this time, we confirmed that there was a patent ductus arteriosus. And then we also saw some coronary anomalies. Okay, there was a left ostia or left ostium situated at one of the pulmonary valve valves, give up to left coronary artery, which is we call Alcapa, which I will present some of the theories later, Alcapa. And then we continue examination on the left chamber of the heart. We cut into the pulmonary vein and the left atrium, and then we cut into the left ventricle. And then so there was more diffuse pearl-white endocardium, which looked like endocardial fibroelastosis or EFE. By the name suggests, it means the endocardium layer of the heart, which is the internal layer of the heart, has a lot of fibrosis and elastic fibers.
Oh.
It's endocardium. Yes. And some people can call it like santan white lah. our coconut santan, like.
Oh, that's true, huh? It does look like santan.
Yeah.
Look,
And then yeah.
remind me of appam, appam with the santan. Okay, now my go on.
Oh. And then the EFE was confirmed with histology. Okay, this is histology. This is the cross section of the heart. This is the endocardium that I mentioned just now. And then this is the myocardium. And the epicardium was not in these pictures. And then when because most of you are not, did not see slide, right? So I give you a normal picture of the heart muscle. This is the H&E, the normal endocardium and myocardium. You can see the normal thickness of the endocardium is just like a few cell layers thin, very thin. But in this EFE, it was thickened. And then we do the mesenteric stain for fibrosis, which was stained blue. This is blue. And it was thickened by fibrosis. Other than that, there was some endocardial fibrosis also, with a lot of interstitial fibrosis and perivascular fibrosis. We show there is heart straining of the heart. The heart is working very hard. Okay. And then there was replacement fibrosis, indicate some ischemic event, okay, or infarction previously. Okay. And then we proceed with elastic Van Gieson staining, a special staining for the elastic fiber. This is the bluish dark color one. This is the elastic fibers in the endocardium, and then it was confirmed to be elastic endocardial fiber elastosis. And then we proceed with the, just now we just in the left ventricle, right? Then we continue the cut into the aorta, and then we saw the aortic valve. Yes, there was only a single right ostium at the right coronary cups.
Single right ostium. Okay, go on, never mind. It's supposed to be tricuspid.
This is aortic valve.
Supposed to be tricuspid, right?
Tricuspid.
Yeah.
Yes. Yeah. Got 3 cups here.
Yeah, there. Here got 3 cups. Okay.
Yep. Yes. One.
Okay.
This is the right cups lah. Right coronary cups. This should be the left coronary cups. Okay. This is the non-coronary cups lah. Okay. Okay, and the lungs appear small, which collapse lah. And then his histology of the lung show no pneumonia lah. And then our other investigation like the blood culture, lung culture, and the IEM screening show no significant finding. So in this case one, the COD at that time after the postmortem examination is congenital heart disease or ACAPA. So I proceed to case 2, quite similar case. Case 2 is more elder than the girl just now. The girl just now is 3 months old, right? And this girl is 11 months old, born term. Okay. And she presented with fever and vomit for 1 day. Later, she became unresponsive and then brought in death. Externally, she looks smaller than her age. Okay, however, there was no suspicious injury, no dysmorphism, no jaundice. The same case, with some abrasion, a branded bruise at the anterior chest consistent with CBR. And then some people may confuse this with bruise, but actually it's not. Because after we die, right? After people die, okay, the heart stops pumping, then the blood all will settle down at the dependent area, which if the patient, the disease was lying supine like this, or the blood inside they will accumulate at the back of the body, except the pressure area. Okay, so this is, you can see the diffusely, homogeneously on the back of the body, except the pressure area. This is hypostasis. No, Bruce, and then the growth parameter shows failure to thrive. Body weight, all are at the right zone. Body weight, head circumference, and BMI. Okay, so as usual, we proceed with brain examination. There was no significant finding. And then we proceed with the abdominal peritoneal examination. Appeared glistening, shiny, normal peritoneum and intestine. And then we'll proceed with the chest examination. There was bilateral pleural effusion, third space fluid retention. And then there was a very big heart, okay, cardiomegaly, bigger than the first case just now. Okay, and then there was pericardial effusion, 33 mils. And then examination of the great vessel of the hearts appear normal, no PTA, no coarctation or aorta. Examination of the heart inside too. This is the lateral view of the heart. And this is the posterior view of the heart. It shows dimpling, right? This is fibrosis, causing thinning of the myocardium of the left ventricle and the anterolateral wall. This is like all the MI. Right? And then examination of the pulmonary artery is same. Okay, at the single left ostium at the pulmonary valve that give out to the left coronary artery. However, in this case, the ductus arteriosus was already obliterated. We have alcapa also. An examination of the left ventricle show this one not very like suntan white, but this one opaque white lah, endocardium diffusely. And then the aortic valve show single right ostium at the aortic valve at the right coronary cups. And in this case, we can see that the left ventricle wall actually very dull looking and hemorrhagic. This is myocardial infarction.
Oh my God.
Yeah, very bad one. And then he's yes.
No. Go on. Never mind.
Okay. And the histology of the EFE to confirm that this is EFE. Yes, same like the first case with thickened endocardium by the fibrosis. Also have replacement fibrosis and interstitial fibrosis. And the fibrosis staining by the Mason trigon is positive. And then the left ventricle, the thinning part just now on the left ventricle free wall also show transmural fibrosis. And the EVG elastic Wang-Geerson stain was positive on the endocardium. And this is confirmed endocardial fibroelastosis. The cross-section of the heart.
Sure.
And this is cross-section. This is the apex. This is cut towards the great vessel here. This is the interventricular septum, the anterior wall, lateral wall, and this is the posterior wall. This is the right ventricle. And then you can see that there was the anterolateral part of the mid-ventricular section already thin, already fibrosis and become very thin and probably aneurysm already. All this whitish thing is the fibrosis. Means that there was a chronic MI already, chronic infarct. And then the myocardium died and then replaced by fibrosis. Or this is fibrosis. This resemble like the myocardial infarction in adult. And estimation, yeah.
Do you choose these cases because I'm a cardiologist?
Pardon?
Do you choose these cases because I'm a cardiologist?
Actually, it's a coincidence.
Yeah. Okay. I'm very go. Okay, go on. Sorry.
Okay. And the estimation of the lungs, this is left lung because got two lobes, right? Right lung got three lobes, one the upper, middle, and the lower lobe. And the left lung appears collapsed. And then palpation of the lung show consolidation, which points toward pneumonia. Then confirmed by histology of the lungs, we show pneumonia. There is a lot of inflammatory infiltrate inside the alveoli. And then the lung culture show Klebsiella pneumoniae. Other investigations like the blood culture and IEM screening were not significant. And for this case, actually she has pneumonia and alcapa, both can cause death. Okay, but as she presented with fever and vomit, which is the one more acute stressor one, So we put pneumonia first and then with alcapa. Both can cause death actually. So anything want to ask me before I go into the theory part of the alcapa and EFE?
Okay. I don't have any. I've heard of alcapa, but I've not seen one myself, and definitely not one in a child, because I don't do congenital.
Oh, okay.
So, maybe you should go on first. I don't know, because we don't know how much. We only know how much we don't know. We don't know anything. I think most of us. Yeah.
Yeah. I also learning from the case also, because
Okay.
alcapa are very rare, right?
Yes.
So alcapa, what is the name? What it means? It is anomalous left coronary artery from the pulmonary artery. Okay, anomalous left coronary artery from the pulmonary artery. It means that actually the left coronary artery and then the right coronary artery that arise from the aortic valve, right? There is at the aortic cups there, the aortic valve there, the cups there was a right and left ostium, right and left ostia. Okay, the left ostia will give out a branch which is the left main trunk or the left CA, and then they will give a branch become the LAD and the LCX, left circumflex.
Yes.
While the right ostium will give a branch and then become our RCA.
So anyone have any questions here? It's very simple. Basically, the coronary artery comes from the aortic root, and the left coronary artery comes from a different origin from the right. So there's two sides to it, and from the left main stem gives up to the LAD, which is the left anterior descending, which comes to the front of the heart and usually supply the septum and the apex. The circumflex goes behind the heart and supplies the behind, and the right, of course, supplies the right and the inferior part. But sometimes the circ also supplies the inferior part, depending on whether it is dominant or not. Yes. So tell us, what is alcapa?
So in alcapa, the left coronary artery, instead of coming out from the aorta, it coming out from the pulmonary artery, which means the left coronary artery now give out the oxygenated blood to our left ventricle, which is a bad news. Okay.
I see, left pulmonary artery. Oh, I see. Okay. Okay. Also
also known as blunt white garland syndrome, because Mr. Blunt is the first one to report this. Okay, alcapa is very rare, accounting for 0.25 to 0.5% of all congenital cardiac disease only. And almost 90% of them die during the first year of life because of massive myocardial injury and following end-stage heart failure, like our case lah. All have heart failure symptom and all have MI. And they all die less than 1 year old. Okay. It's a common cause.
your first child was how old, sorry?
3 months old and 11 months old.
Oh, okay, okay.
This alcapa is a common cause of myocardial infarction in children. Okay, don't say that children don't have MI. Children also have MI. Okay, the clinical features of this alcapa are not specific. Always sometimes will misdiagnosed as EFE. Okay, actually, some patient will be diagnosed at EFE first, and then they miss the alcapa.
What's EFE?
The endocardial fibroelastosis, the santang just now. The
Oh, I
santang
see, I
alcapa
see.
just now. Yeah.
That EFE actually is a pathological finding, or is it a diagnosis
It's a pathological finding.
Okay.
In the diagnosis, yes, yes, a diagnosis also, yes.
So it's a diagnosis also.
Yep.
So in EFE, it's a disease by itself.
Yes, it can be a disease by itself or associated with other people.
Associated with other diseases.
Are there other cardiac
It
anomalies?
can be a primary cause of death in
Can, yes,
children.
can.
So
It can cause death also.
what? Okay, if EFE is a primary disease, what is the pathology behind EFE?
Etiology is unknown.
Or pathology is unknown. It's like idiopathic.
Yes, there is some hypothesis only, but not being proved.
Okay.
Yeah, EFE will be taught also later.
Okay.
Okay. So these infants with Alcapa usually experience pneumonia, like in our second case, and then heart failure, like both our case, within the first few months of life, and other symptoms are like the failure to thrive, like our case, and other symptoms like profuse sweating, pallor, dyspnea, atypical chest pain while eating or crying. Unfortunately for our case, we did not get more history from the parents lah, for all these other symptoms.
But the symptoms is exactly like angina lah.
Yes, the MI lah, yeah.
Yeah.
And the pathophysiology of Alcapa, okay, we talk from the fetus period until they are being born, okay? During the fetal period, this anomalous LCA from the pulmonary artery to be supplied by the pulmonary artery, right?
Yes.
Because the pulmonary vascular resistance is high inside the womb, okay? Despite relatively low oxygen saturation, the effective perfusion pressure is high enough to exclude overt myocardial ischemia. That means if they are not being born yet, they are okay lah with Alcapa inside the mother's uterus lah. Okay, but after birth, the pulmonary artery pressure decrease, the lungs open up, right? Pulmonary pressure resistance decrease. And then this pulmonary artery pressure decrease also by physiological occlusion of ductus arteriosus. And then it causes a decreasing flow rate in the left coronary artery, in the anomalous left coronary artery, and a conversion of the blood flow in the left coronary artery toward the pulmonary artery. It feels like the blood was, instead of supplying to the anomalous LCA, is sucked back the blood on the LCA because of the low pressure at the pulmonary artery there.
So if there is a large shunt, if there is a large intracardiac shunt, let's say a large PDA, a large ASD, will the patient, I mean, hypothetically, can the patient survive longer?
Yes, if there is a higher pressure at the pulmonary there.
Yes.
And then more oxygen supply to the left
Right.
ventricle, they can survive better.
Okay.
So because of this ischemia, right, the pulmonary, the LCA already is supplied by the pulmonary artery, which is the oxygen blood, and now the pulmonary artery want to steal the blood back into itself. The left ventricle suffer this ischemia, and then by this it stimulate the coronary artery collateral vessel develop, which is from the RCA towards the abnormal LCA to help that LCA. Later I'll show you the picture. However, because the LCA is connected to a low pressure pulmonary artery, the collateral flow tends to pass into the pulmonary artery rather than into the LCA itself. This is we call the pulmonary coronary spill with a left to right shunt inside the coronary. Okay. And this is like a vicious cycle. Okay. The right CA develop this collateral vessel, want to help this LCA, but because of the pulmonary artery pressure is low, the blood was sucked back into the pulmonary artery. This resulted in diminished perfusion of the left ventricular muscle, extensive myocardial ischemia, necrosis, and fibrosis. These changes could lead to other problems like left ventricular dilatation, mitral regurg, and impaired cardiac function. This is the picture. This is during fetal period. Okay, this is the aorta, our aorta, aortic valve. This is the right ostium that I mentioned just now. It come out to become the right coronary artery. It supply the oxygenated blood. This is the pulmonary valve. The anomalous LCA coming out from the pulmonary valve supply the oxygenated blood to the LV, left ventricle. But however, because in fetus, there was this all foramen ovale, all this stain, DDA, all this stain, the blood was mixed, right?
Yes.
And then the left ventricle did not suffer much damage, no damage, can be said at the fetus period. But however, after being born, the pulmonary artery pressure dropped. Okay, and then this is beside it supply the deoxygenated blood to the left ventricle. It also suck back the blood, okay, into the pulmonary artery. And then because it has this ischemia, it stimulates the right coronary artery to produce this collateral vessel, okay, to help supply this LAD, okay. And then when times pass by, this RCA will become bigger, okay, because they want to help this poor LCA, right? However, because of this pulmonary artery, there is low pressure, it's still shunt back, okay.
Shunt back to
So
the.
the only treatment is surgery, okay.
But has it been reported to pick up early enough to go for surgery in patients like this?
Pick up early enough. The early part I cannot answer, but yes, if the patient can be diagnosed early, they will go through the surgery repairment and then with good survival.
It's very difficult to diagnose because who does angiogram on the baby anyway?
Yeah.
Yeah, okay, go on.
And then it's a rare disease
Yeah.
also.
Okay.
Maybe because it's sometimes associated with the endocardial fibroelastosis, right? The thickened endocardium. So maybe when we see the EFE, we can try to look for ACAPA, something like that.
Okay.
So more about ACAPA, the extent of collateral pathway development between the right and the left coronary artery determines the extent of the myocardial ischemia, how good they develop collateral pathway. Only a very few with extensive collateral circulation when the right coronary artery can survive into adulthood. Not all will die, some people do survive. If there is pulmonary hypertension, as with large VSD, left ventricular perfusion may be adequate to prevent ischemia.
So that's correct.
So now VSD is a survivor for them. It's a good thing for them. So grossly for ACAPA, we can see very clearly the LAD from the LCA is from the pulmonary valve, okay? And then other than that, there may be diffuse EFE, endocardial fibroelastosis of the left ventricle. And then the MI, myocardial infarction binding, which is the thinning, fibrosis, scarring of the anterior lateral left ventricle wall and apex. Okay, sometimes there may be mural thrombi.
Okay, can I ask you this endocardial fibroelastosis? Okay, is it due to the persistent ischemia or is it due to myocardial death?
It's a response to a stress.
I see. Okay, so let's say, because I don't do pathology and of course I save patients, so I don't get to do pathology. So let's say my patients do have persistent ischemia as an adult. Will they have this diffuse endocardial fibroelastosis, you think?
That one will be maybe in the next slide.
Okay, sorry. I always ask questions.
The adult,
yeah,
adult
okay.
ACAPA, right? Okay.
Okay, go on. Let's go.
So adult ACAPA, because there is survival, right?
Okay.
So about 15% of infant ACAPA patients is 50%, the myocardial blood flow somehow can sustain the myocardial function at rest or even during exercise, that they can survive, reach the adult life. Grossly, the LCA is thin wall, resembling like a vein.
Oh.
And the heart is usually enlarged, but not as much in the infants. And there is usually no EFE, endocardial fibroelastosis. There is their finding.
Okay.
However, there is usually scarring and a calcification of the left ventricle of the anterolateral papillary muscle, and occasionally even at the adjacent left ventricle. That means all the findings are less severe. Okay. Does it answer your?
No. I'm not talking about adult Al-Kappa. I'm
Mm.
talking whether this EFE is seen in patients who actually have coronary artery disease in adult.
Oh, no.
No, ah?
It's a fibrosis only, no elastic component.
I see.
Yes.
So why does Al-Kappa give this elastosis and not other kind of ischemia then?
This Al-Kappa, yes, have just now got pictures, the histology, right?
Yes.
Myocardium do have fibrosis. There is the ischemic, the ischemic part of the
Yes, the one
Al-Kappa.
is the fibrosis is due to the muscle death.
Yes,
Uh,
yes.
But this endocardial fibroelastosis, the suntan look, right? It's not because of muscle death, right?
It didn't explain as that lah in the book. Okay.
Okay.
So
So
go into.
okay, go on. You go on first. Okay.
Well, maybe after you see this first lah. Okay.
Yes, that's right.
So endocardial fibroelastosis, or EFE, is a thickening of the endocardium. It
Okay.
specifically mentioned endocardium only by layers of collagenous, which is fibrosis, and elastic fibers. Okay. It causes the restrictive cardiomyopathy. Accounts for 1%. Just now the Al-Kappa is just 0.25 to 0.5%, right? This one is 1% of congenital heart disease with a male to female ratio 1:1.5, means female more lah. And our two patients are both female.
Oh.
Approximately 80% of the patients present with congestive heart failure within the first year of life. There was no unifying hypothesis of etiology.
Oh,
Don't know how it
you
developed.
explained everything to me already. Okay.
And there was classification of the EFE. This classification did not indicate the etiology lah. Since we already said the etiology and the morphology are not related. It's more for morphology, okay? Morphology classification, which is the primary and the secondary. Primary in which it stands alone. It's just an EFE with no other anomalies, with the exception of abnormal mitral valve sometimes. And the secondary one is when you found other cardiac anomalies. For example, in 2 of our cases with Al-Kappa, which is the number 4 here, anomalous origin of one or more coronary arteries from the pulmonary trunk. So both our cases actually have Al-Kappa with secondary EFE. And then the hypothesis of the EFE, how EFE developed. Possible theory for the etiology of primary one, primary EFE fall into 3 categories: inflammatory, mechanical, hereditary. Okay, but it's just theories. Okay. And then this person, Moller, he stated that EFE actually is a secondary response in a certain individual, either to an intrinsic inherited myocardial defect, which result in inefficient myocardial function, or to a grossly abnormal hemodynamics associated with a congenitally malformed heart. I think what it means is a EFE is a secondary response to the primary type. The intrinsic inherited myocardium, maybe say the primary EFE, the congenitally malformed is the secondary EFE.
So this EFE seems to be something that is pertaining to a pathology in children mainly.
Yeah, in children. Yeah.
I think it's not.
And then the infants with this EFE develop symptoms at early age. Okay. They seem to be well until develop the sign of left heart failure, which may be preceded by respiratory infection, just like the Alcapa. Okay. There was no significant murmurs, which is quite very difficult to diagnose clinically. Okay. And differential diagnosis is the Alcapa and POMP and acute myocarditis. So grossly for EFE is pearly or opaque white or suntan white appearance of the endocardium, especially of the ventricles. It always found in the heart under stress and usually in the chamber most subject to stress, which is the left ventricle. So mostly it's a pearly or opaque white endocardium at the left ventricle. Its severity is related to the time of onset of the underlying cardiac stress. The longer that patient sustain the stress, the more pearly or diffuse opaque white endocardium is. And this is a textbook picture of the EFE, endocardial fibroelastosis. Diffuse opaque pearl white of the endocardium. You see the endocardium only. And this is the HNE of the endocardium and myocardium. The endocardium was greatly thickened by fibrosis, which is compound with mesenteric stent and by elastic fiber with the stent positive with elastic vangus. There was some subendocardial fibrosis also. And there was another entity that's similar looking with the endocardial fibroelastosis, which is endomyocardial fibrosis or EMF or Davis disease. By the name suggests it only fibrosis, not elastic component. And then it was at the endocardium and myocardium. It was first described in Uganda. Okay, initially termed tropical endocardial disease or endocardial fibroelastosis. Okay, now we call it EMF, endomyocardial fibrosis. It endemic in Africa. This is the difference with the EFE. This EMF endemic in Africa and high frequency Asia and South America. Affects predominantly children and young adults. Grimaldi called it a disease of poverty, since it afflicts the rural populations and low-income countries. The epidemiology is different for EMF and when compare EMF with EFE. And then it appears look a bit like the Santan white just now, right? Then we have to confirm by see the case and then confirm with histology. Okay. The EMF was due to the deposition of fibrous tissue only, no elastic tissue in the endocardium and myocardium and lead to restrictive cardiomyopathy. It also lead to restrictive cardiomyopathy too. And then patient also died due to heart failure, arrhythmias and thromboembolism. The etiology is unknown also. But some theories say that it's eosinophilia, infections, autoimmunity. This although both EFE and EMF have unknown etiology, but their theories are different also. Okay, for this, like this EMF is hypereosinophilia, infections like malaria, helminth infection, and some theory is like autoimmunity. Okay, this endomyocardial fibrosis more grossly more involves the right ventricle and left ventricle epiphysis and subvalvular apparatus. And because at the subvalvular apparatus, it can affect the valve also. Sometimes have valve impairment. With the epidemiological difference when compared with EFE, which is more in the Africa and the children, young adult there. Okay. And the EFE, which is the endocardial fibroelastosis, has more diffuse involvement of the left ventricle, which is the more stressed part of the heart, the left ventricle. And that's all.
Good. I'm very, very Oh, I love alpaca lah. That's my one. That's my number 2 favorite animal. My number 1 is panda.
Oh, okay.
And alpaca are the cutest animal in the world. They're very, very smart, and very cute. I saw them in Peru and Bolivia when I went there. Are there any questions? Because any questions at all? Okay. How do you, when you do all this post-mortem, okay,
Yes.
do the parents have to, like this death, right, is a sudden death, parents have to consent or not, or it must be done?
There is 2 types of postmortem or autopsy in Malaysia lah, okay. The one is the clinical autopsy, the one that need family consent. This kind of autopsy is for academic reason.
I
Okay.
see. Okay. Means
Another
we're
one is
already quite certain of the cause of death.
they have some query, they want to learn something, they want to know why is it like that, or this disease, something like that. So they do it for, like in the miscarriage, multiple miscarriage, they want to do a clinical autopsy lah. There was no medical legal thing inside there.
Okay.
The academic, the clinical autopsy that was done by histopathologists lah. Not as for forensic pathologists, we do the forensic autopsy, which was all the brought in that is police case. If the police ask for postmortem, then it's a forensic autopsy lah. And this case, the police case, police give us the warrant, which is called Call 61, to give us, and then when we receive this warrant, this order, we will proceed with postmortem. The family consent and whoever consent is not needed.
Okay. So in this case, like this case, right, in your the baby brought in like this, don't need consent, right?
No need. It's brought in that police case.
Or it's police case.
Yeah, brought in that.
Oh, I see. So you definitely, the parents have no say.
Yep.
Okay. And usually you will do within 24 hours of the case being brought in?
Yes, and see the timing and then how many cases that they will do and planning lah. And before the COVID can do it on the same day lah, but now COVID depend lah. If you can do a gene expert or not, something like that.
I see. So most times you try to do it on the same day lah.
Yep.
And even if it's like other, like let's say we say Muslim have to be buried within 24 hours, it doesn't matter anymore, right?
We do it as soon as possible.
Okay, do it as soon as possible. Okay, this is the QR code for doctors, so you yourself can do. Okay, use the MMA app and scan it, which I'm doing now with your handphone. So if you're watching from your handphone, you can't actually scan it with it, because so you have to be watching it with on your laptop and scan it with your handphone. Yeah. And these are all our social media platform. Please do follow us. Okay. And since there's no questions, I think we will end here. It's been very interesting. Maybe we can do more other cases in the near future.
On trauma case lah.
Trauma case. Okay, can
trauma case actually quite straightforward. But maybe like learn the injuries lah, learn about the injuries.
So this case also quite interesting to me lah, because I'm also a cardiologist and I've not seen Alcapa before. So and then of course it's all heart failure and all also, but in a child. So link. Okay, for all the nurses, let me just stop share first. Okay, and I'll stop recording.